this lecture, we will discuss the U wave, specifically what it represents, how it may appear on the EKG, and its clinical significance. The U wave is a small, low-frequency diastolic deflection that is not always present on the EKG. However, if it is present, it begins with the second heart sound at the onset of ventricular relaxation, that is after the end of the T wave, but before the next P wave. So if you look here, we have our P wave, this is our QRS complex, and then we have our T wave, okay? We don't have a U wave here, but if it were to appear, it appears somewhere in this region, right? Here's ventricular diastole, where the ventricles are starting to relax, okay? And that's where we'll see it. If you look here, here's our U wave present, okay? This is just a pictorial depiction of it, okay? And then we'll also see a U wave here that we'll discuss shortly, okay? So again, a low frequency diastolic deflection, and it's not always present. Now the cardiac event it represents remains unclear. A few hypotheses have been proposed, although there is still no consensus. Now if a U wave is present, the duration of its ascent, meaning it's going up, all right, its rise, tends to be less than or equal to the duration of its descent, so its fall, which seems to be nearly the opposite of the normal asymmetric T waves, slow ascent and rapid descent, okay? Remember when we talked about T waves, they had that asymmetric appearance, okay, where you had this ascent, right? Imagine this is our peak here. Notice there's asymmetry. Remember we take our points and make this. Notice how each side is different from each other, and where there's the slow ascent going up and more of a rapid downfall, okay? And we're saying with these U waves, you tend to have it almost the opposite, or it could be equal as well, all right? So anyways, now the orientation of the U wave will still be the same as the T wave, okay? So it's going to go in the same direction, and its axis is also similar to that of the T wave. That is directed leftward, inferiorly, and often anteriorly in the horizontal plane. The U wave amplitude is normally less than the preceding T wave's amplitude and rarely goes above 2 millimeters, which is 2 of the small boxes, or 0.2 millivolts. The U wave amplitude appears to vary directly with the T wave amplitude, meaning if the T wave amplitude goes up, so will the U wave. And for this reason, the U wave amplitude is often greatest in leads V2 and V3. These are the same leads in which the amplitude is greatest for T waves. Now, in terms of clinical significance of the U wave, well, it's often benign and seen in bradycardia, that is, when the heart rate is slow. It is considered a potential marker of hypokalemia. So when serum potassium levels fall, you may see this. Therefore, if you see U waves, you have certainly ruled out hyperkalemia from your differential, okay? Because if they're present, then you certainly likely, or you may have hypokalemia, but you don't have hyperkalemia. Now, in addition, sometimes the U wave can fuse with the end of the preceding T wave, which we call TU fusion. In such cases, it can lead to an inaccurate measurement of the QT interval, making it appear falsely prolonged. In the QT interval lecture, we discussed when to include the U wave when calculating the QT interval. Make sure to listen to that lecture if you haven't done so already. In general, you include the U wave in the QT interval calculation if it's greater than 1 millimeter in amplitude, and exclude it if it's not. So what I mean by this, right, here's our T wave. We said this was our U wave here at the end, and what I'm saying is if that amplitude is greater than 1 millimeter, then you will include it in your calculation of the QT interval. Remember, the QT interval is from the beginning of our QRS complex, this point here, this is our QRS complex, to the end of our T wave, okay? And if you have that U wave that's present there and it's greater than 1 millimeter, then you'll include it in our measurement, okay? And remember, we do so, let's just erase some of this so you can see. Remember, you find that green line here is our baseline, so you measure that out. You take the slope, the greatest slope, and you find the intersecting area, and that's the end of the T wave. Now, if it's less than 1 millimeter, then you would take it from this point here. Okay, so that's where the U wave can cause a falsely prolonged QT interval. All right, let's briefly review what we discussed before we end. Now, the U wave we said is a small, low-frequency diastolic deflection. Okay, and that diastolic period, it's not always present, and if it's present, it begins with the second heart sound at the onset of ventricular relaxation during diastole and after the end of the T wave, okay, but before the preceding or the next P wave. So if you look here, this would be our next P wave, okay, and it's coming before it. Here's our T wave, it's coming somewhere in this area, all right? Now, we said the cardiac event still remains unclear. There's some hypotheses that have been proposed, but still there's no clear consensus. The U wave ascent duration tends to be less than or equal to the descent duration, okay? And then we talked about the U wave orientation, as well as the axis seems to be similar to that of the T wave, okay? The axis leftward, inferiorly, and anteriorly directed, okay? So if we draw that out, it'd be heading in this direction, all right? Same where our QRS, T wave, and U wave. Now, the U wave amplitude tends to be less than that of the T wave. It rarely goes beyond 0.2 millivolts, which is 2 millimeters. It varies directly with the T wave. So if the T wave is greater, okay, you'll get an increase in the U wave, okay? So as the T wave goes up in amplitude, so will the U wave. Often it's greatest in leads V2 and V3, where we also see the greatest T waves, okay? Now clinically, this is often benign. It's seen in slow heart rates, bradycardia, and it's a potential sign of hypokalemia, okay? One of the things to be aware of. If you see U waves, it certainly rules out hyperkalemia, okay? Now it may cause inaccurate QT interval measurement, right? Falsely prolonging it because of that TU fusion that we saw there. Well, that's the end of this lecture. We discussed the U wave, specifically what it represents, how it may appear on the EKG, and its clinical significance. I hope you learned something.